Consensus, yes or no? The first step, if you're going to make the diagnosis and treat it, 2 to 4 weeks of antibiotics to kill the spirochete. Yes, no, what? Yes?
No.
No. Why not?
Well, I think I've seen some people that works, but I think there's always the outlier in the bell curve. There's some people that a few weeks doesn't work for some reason. Maybe they have a complex infection. There's more than one pathogen.
But I said first step. Would that be the first step for most people?
Yes, I think that would be.
Well,
Okay.
doesn't it depend on the manifestation, though? I mean, if somebody comes to you with meningitis, you're not going to give them 2 weeks of doxycycline.
No, but you're not going to give them more than 8 weeks, probably.
Well,
of
but
the
my
antibiotic
point being
program.
is that it depends.
You're right. It depends.
Sure.
Okay. Consensus or not? My guess is going to be no, by the way. I'm putting my money on no. What to do for the subset of patients who continue to experience symptoms after this 2 to 4 to 6 weeks of antibiotics?
Careful differential diagnosis and careful empathetic review of their clinical picture.
And not telling them that it's all in their head and sending them
Right,
out the
and
door.
being supportive.
Absolutely.
With the recognition that there are going to be those of us who feel a greater percentage of them probably have active infection as opposed to another group of people who will not, so that the recommendations coming out of that review is going to be different.
And to reiterate, looking for other potential explanations.
Differential
And
diagnosis.
don't just give antibiotics, but treat the symptoms as well.
Okay.
We need to do both.
The rationale, let's boil it down. I'm trying to get at least some clarity here. The rationale for or against using a longer course of antibiotics in patients who have persistent symptoms.
If you feel that there's a threshold that you've achieved, that you feel that there's active infection, and we've all discussed what that means, and that threshold is different for individuals. If you feel that that's the case, then by not doing that, you potentially run the risk of not having adequate therapeutic gains. The other component, and this goes to the MS patients, a number of them, actually all 3 of them, were recommended by their neurologists to be on immune suppressive drugs, which could have made their conditions worse had they not been identified as having an infection.
Okay. Now, we've had an awful lot of bomb throwing here today. There's an awful lot of grenades flying through the air out there. What do we need to reach a better consensus on the issues that we've discussed?
Better testing.
Better testing. What kind of testing are we looking for?
Let's just back up for a second. Better science.
Okay.
Better science looking at clinical markers, biomarkers, as you were saying, looking at better testing, looking at what are the sensitive questions that we can, I don't mean sensitive in the sense of
Statistically,
I'm caring for you.
Sure.
That's important too, but sensitive in the sense of statistics.
Sure.
I think what we need to do is put down the grenades, put down the bombs, stop accusing each other of somehow having nefarious interests, and let's have a civil, I realize this is the United States in the year 2017, so the word civil has been thrown out the door. But maybe in this microcosm, we can be civil and have a conversation about this and make the best of everybody's talents and experiences.
One solution is more programs like this. This is great. I think when it's face-to-face and collegial, we can help to reconcile these differences and iron them out. We're coming at it from very different angles.
Yes.
Right.
I think this is very useful, and I think better disease definition is critical.
Okay.
And I was just going to say that over the years, that many times we have asked to have more dialogue. We've contacted the IDSA, we've tried to sit down with them. We actually had them at our LDA Columbia CME conference several years ago. It was the first time they were on the same stage. Believe it or not, we've advocated for that for decades, to get people together to have a discussion. But unfortunately, there's been unwillingness, and I was very happy that Dr. Sigal today agreed to come in and sit at the same table as us, because it doesn't happen very often.
But it goes the other way
And
around,
we
you know.
need- No,
I've invited
excuse
people.
me, well, who?
I've invited clinicians in New Jersey who see hundreds of patients with Lyme disease to sit down with me to come up with research studies that would allow us to understand what's going on in those people, understand how they respond to antibiotics, understand what biomarkers might be useful, and the last time I saw them was when they walked out the door. They didn't follow through on their
Well,
on
perhaps
their interests.
the reason for that may be because for a number of decades, our physicians have been gone after by medical boards just for treatment long-term of patients with Lyme disease. And that's been very problematic. And we have a number of physicians that have had sanctions and so on. So the climate of fear that has existed, those physicians don't necessarily want to put them, if they're really practicing physicians, they don't want to put themselves out there because
I'm not
they
sure
are
that's the
brought up
explanation.
on
But the
charges.
BME, the Board of Medical
Well-
Examiners in the state of New Jersey, has looked at many, many clinicians.
I know what they look at, yes.
Yeah, you know, unfortunately. But what I was asking was, if you see these patients, let's do a clinical study so we can understand what's going on with these patients. And they were never forthcoming. All I can do is invite, and in a civil manner, try to encourage them to be part of a scientific trial.
I think part of the problem is also that when there have been clinical trials, and sometimes the treating physicians have supported those trials, and they have said to patients, maybe you should enter those trials always end up that the patients are basically not being helped by antibiotics. Again, broad brush conclusions, and so those physicians and those patients don't want to even participate in those trials.
Let me see if I understand that point.
Yes.
If there are trials that are undergoing, that are underway, patients get enrolled in these trials.
Right.
But the results are that antibiotics may not be the right answer. They didn't give you the answer you wanted. Does that mean that the trial was bad?
No. That isn't the situation. The conclusions that were drawn in some of these studies, in the 4 from the NIH, and Sam alluded to 2 of them before, the conclusions were drawn, were broad brushed. It should have said that in this subset of patients that was in this trial, with these particular antibiotics for this duration of therapy, that the antibiotics maybe did not help them, or in 2 cases actually did, but they said that they didn't. So that is the broad brushing.
One of the criticisms that I've heard of the quote unquote long-term antibiotic trials is that the duration was insufficient, and that had there been a longer trial of antibiotics, there might have been a better outcome. I've heard this from other people. I'm not putting words in your mouth, Sam. I just want to ask you.
Well, and that is a potential, but there are other confounding variables, such as in the Klumpner study, most people were sick for between 4.5 and 5.5 years, many of whom had gone through the very protocols that were used in the study. So you're self-selecting failure. And it's a matter of also not identifying treatment of co-infections, which
So you're taking issue with the design of the study.
Yes.
Had the study been a little bit more real-world oriented.
Right. The problem is you got to control your variables, and there are so many variables that you've got to control.
And PCR positive patients were excluded from the study. They should have been the ones that were studied.
I agree with you.
You know, it sounds to me, not being involved in the creation of these studies, not being at the table, that if everybody got together and agreed a priori on the construction of the study and the goals and endpoints, then everybody might agree better when they got the data.
We're in the process of actually doing that. There's a work group of about 15 of us that are trying to put that together.
If I can be of assistance, let me know.
I just want to point out, I haven't seen this since the United Nations was formed. This is
You know,
great.
one of the things in the
And
pharmaceutical
both
industry,
schools of thought are involved.
in the pharmaceutical industry, and that's not a dirty word, in the pharmaceutical industry, when you have a study of, say, a drug for rheumatoid arthritis, so we'll go far afield, you have to come up with entry criteria that bring in patients who are as homogeneous as possible, because you're going to be randomizing them.
Right.
And if you randomize them and they're not homogeneous, you stand a chance of asymmetric distribution of patients, and your study goes up in smoke.
Right.
So I'm not defending anybody's study design, by the way. I'm just saying that when you do a study, you have to be really rigorous about bringing in as homogeneous a population as possible. Now, for some reason, they decided to exclude PCR-positive patients. I don't know what the reasoning was there, but the idea is to not make it so, not make the entry criteria so small that you can't get the real world in, but not so broad as to make it a garbage study. There's got to be some middle ground.